All right, so thank you, everyone. So we'll move on to our final speaker of this session. Dr. Rob Headrick he's chief of thoracic surgery at the Reese Skillern Cancer Institute in Chattanooga, Tennessee. He did his undergraduate degree at Vanderbilt, followed by a residency at University of Tennessee, and then went on to do his fellowship at Mayo Clinic in Rochester. He's got a very cool talk planned to discuss mobile lung cancer screening. So can't wait to hear about this. Dr. Headrick, thank you.
Thank you. So it's great to be here and to close out a conference. It's a little bit more lighthearted. It's more of a storytelling, so appropriate for the end of the day. I was telling my wife before I came here, I dreamed a lot as a kid of all the different things that I could do in life, and one of them was to be in the World Series, bottom of the ninth inning, bases loaded, and hit that home run, that grand slam. So that's probably not ever going to happen, but maybe we hit a home run here today and get us onto the crawfish and the fried chicken. So these are my disclosures. One of the things that, going back into 2015, I really gave up the cardiac side of my practice, believing this was going to be the biggest opportunity in healthcare, and I still believe it is. But we're having our first screening test for lung cancer that was really going to change the disease. And I thought my office was going to be flooded with patients. What I'm going to tell you is sort of a story of frustration that most of us lived that journey, and simply a solution that I came up with my advisory panel, which is a hound dog and my wife, to how do we solve this without having to go to Washington, come up with new legislation. It really ties into what our keynote speaker told us this morning of the opportunities, particularly in the rural communities, where there is a disparity in longevity, but also in survival with diseases like lung cancer and how big of an impact it can be. I'm also going to give you some insight into what we're doing. We're going to do over the next year. Actually, Dr. Dozier is going to be doing in southern Louisiana and trying to help address this problem. So, taking you back to 2017, frustrated. I'm in the back of the car. My hound dog is sitting there looking at me. If you ever seen a beagle, they just have that face like it's just not that hard. Come on, guy. And I was driving to Mississippi, and I was frustrated, and he just had that look of, you need a pep talk. So I got on my computer, and I was searching, and I came across this, which was what I needed.
We all need a pep talk. The world needs you to stop being boring. Yeah, you. Boring is easy. Everybody can be boring, but you're gooder than that. Life is not a game, people. Life isn't a cereal either. Well, it is a cereal. And if life is a game, aren't we all on the same team? I mean, really, right? I'm on your team, be on my team. This is life, people. You got air coming through your nose. You got heartbeat. That means it's time to do something. A poem. Two roads diverged in the woods, and I took the road less traveled. It hurt, man! Really bad. Rocks, thorns, and glass. My pants broke. Wah! Not cool, Robert Frost. But what if there really were two paths? I want to be the one that leads to awesome. It's like that dude Journey said, don't stop believing unless you dream stupid. Then you should get a better dream. I think that's how it goes. Get a better dream and keep going. Keep going, and keep going. What if Michael Jordan have quit? Well, he did quit. No, he retired. Yeah, that's right. He retired. But before that, in high school, what if he quit when he didn't make the team? He would have never made Space Jam. And I love Space Jam. What will be your Space Jam? What will you create will make the world awesome? Nothing if you keep sitting there. That's why I'm talking to you today. This is your time. This is my time. It's our time. We can make every day better for each other. If we're all on the same team, let's start acting like it. We got work to do. We can cry about it, or we can dance about it. We were made to be awesome. Let's get out there. I don't know everything. I'm just a kid. But I I do know this. It's everybody's duty to give the world a reason to thanks. So get to it. You've just been pep talked. Create something that will make the world awesome.
Well, I certainly wanted to make the world awesome.
Play ball.
It was definitely what I needed at that moment. You know, what was going to be my Space Jam? Well, this journey took me to Corinth, Mississippi, where my father-in-law lives. And every Saturday when we get there, or Sunday morning, he would tell the guys, the doctor's coming. I would meet at the liar's table. They'd buy me a coffee and a sausage biscuit, and I'd literally be there for half the day. And I had my phone out with Google, and they were showing me how difficult healthcare was, not only to understand, but to execute. And they really had the same thing I wanted, was to live longer, but they didn't know how to live longer. And we'd made it so complicated, and the words to all these drugs. Think of all the talks we've had today, and be sitting there trying to explain this to a layperson at a breakfast table. We had created a healthcare system that wasn't serving these people. And I felt like that was clearly the first step of understanding it. On the way back, I started looking at life expectancy. 17% of our GDP is spent, and yet we lost years during COVID. That's understandable, but we've still never really achieved much. We've been stuck in this one place despite spending $4 trillion on healthcare. So I go, well, what's the top 10 causes of death? And you really realize that half of it, in fact, most of it comes through the chest. So somewhere in there, this lung cancer screening opportunity that we were failing at getting out to the public really had to be a part of that solution if I wanted to change survival, if I wanted to make some impact. Well, I took a look at Tennessee, and the same thing with Louisiana, and just separate out the number of lung cancer deaths. It actually comes in at number 4 as a cause of death. We put so much other attention and other things that if I just focused on heart disease and lung cancer, I'm going to address 40% of the things that are number 1 on a death certificate in Louisiana. In Tennessee, it turns out it's about 45, 47%. Maybe this isn't that complicated. We're trying to make it too complicated. So before I got home, I had pulled up our Tennessee.gov data, and I was really trying to compare, being competitive, and that's how surgeons are, and any of us in healthcare and medicine. How am I doing compared to Vanderbilt? How am I doing compared to Knoxville, Memphis? And what it was striking to me was that anywhere where there was a cancer center or a urban setting where access to healthcare was easier, our mortalities for lung cancer were less. The prevalence of the disease was also less, and I was trying to understand that. But all these communities where the green is, particularly up towards Kentucky, if you live, and Chattanooga is down in this bottom corner here, this is Polk County, where it's about an hour, hour and a half away from us, beautiful territory, but there's no access to health care. All the red X's are where we shut down our rural hospital systems, and it certainly became obvious there's no way they knew about lung screening, nor were they going to drive an hour, hour and a half, 2 hours to come see me for a test they really didn't want to get to begin with. And you can do the same thing with Louisiana. You look at the pockets of where we're missing out on health care, and it usually comes down to access and education. So by the time I'd come back from Mississippi, it was clear that we're putting together a puzzle with lung screening. It's new to all of us. But somewhere in there, I had to come up with a mobile solution of just like what I was doing at the liar's table in a small town in Mississippi. I had to take the education piece and the healthcare tool to those communities. It sounds really simple, except I went to go buy one, and you couldn't buy one. I had a proposal from 3 different companies. I'd ask them, well, how many did you build? And they said, none. Well, what does it cost to build it? Not sure. What's the cost to operate it? Don't have a clue. So it kind of left me with a point of, let's just try to solve this by coming up with a prototype. The hospital said they would buy into it. Several other of the vendors all kind of said, let's give it a try. And we really had a 3-year end point that if it can't sustain itself, let's shut it down. It was a bad idea, but a good try. We wanted to see the financials, but also would people accept it? Could we change a population or a community? And one of our target cities was Spring City, Tennessee, and I'm going to give you the update on that towards the end. So how do you build one? Never built anything before. So I went to what I knew, Forest City, Iowa, kind of close to Rochester. Winnebago's home plant there. They have an assembly line. So I said, I want the biggest Winnebago, but don't put anything in it. Just want the shell. So we took their chassis, took it off the assembly line with nothing in it, drove it up to upstate New York near Cooperstown and took an old 16-slice scanner, placed in it, kind of modified it so we thought it would hold up better to the rugged roads of East Tennessee. Lead lined the rooms, got everybody to sign off on it that it was safe and drivable, and brought it back to Chattanooga. And in 2018, started driving it around. This is what it looked like. And the only thing I knew to build was what we see in hospitals, imaging centers. There's a doorway that comes in, there's a control room, you go to the scanner. And my Vanderbilt engineering degree probably was challenged because I made so many mistakes in doing this, but was part of that learning curve. The chassis wasn't big enough. Screening's about high volume, so we had one way in and one way out. And of course, none of us knew COVID was coming and the need for keeping space and people's protection. But despite all this, we published our financials on the 1 year and a 5-year pro forma in the Annals of Thoracic Surgery. It took a lot to get it in the journal because it was really a business paper, but I felt like it was important as to, is this even a potential solution to the problem? It actually got highlighted as their article of the month, and what took off after that was really the start of what I felt like I may be onto something, that this is what that people were craving, a different way of healthcare. One of the findings from the study I'll just highlight on because it'll come back into, what did we find that was the most common non-pulmonary finding in this population was severe coronary disease. So my dad, who was a thoracic surgeon from the 50s, was at Vanderbilt during those pioneering days, smoked his whole life, couldn't quit, knew he was going to die of lung cancer in 1995. Every trial had failed looking at a screening tool. What did he die of in 1995? A heart attack. So you start also getting this idea that maybe it's even bigger than lung screening. But how do we put it all together? Well, it got released. Over 250 TV stations picked up the idea, and it wasn't about lung screening, it was about the easiest doctor visit. Internet news media has picked it up. We had Sirius Radio, the doctor show, everybody calling, not to talk about lung screening, but a different way of healthcare. But in there, I got to spend my little 5 or 10 minutes talking about lung screening and who benefited from it. For the first time, I was getting to talk about something that I wanted to talk about that people weren't listening to. So what did we learn from this journey? Well, the mobile bus was designed completely wrong, but that's part of the learning piece. We needed a much more robust chassis. It needed to have a 10-year lifespan, and to do that, we had to go from a 27,000-pound to 52,000-pound chassis. We also wanted to cut out the middleman. You know, this needs to be an economic solution. It has to cash flow. It's got to be sustainable. It's not something that you want to keep going back to donors every year. The second piece was mobile screening worked. Surprisingly, you can get people to get on the bus if you make it easy, if you put it right there at their front door, their church, their place of business. But it's a high volume test. So screening, you need to get high volume to be able to find the disease you're looking at. So going and screening 5 people in a community and driving home, I wasn't changing anything. So we had to really redesign the throughput of the bus and put some other concepts into it. Then the lung screening finances, it cash flows as long as it's attached to the hospital. You're taking somebody who's disengaged in healthcare, who's not going to the primary care doctor, sitting on their couch, or sitting at the liar's table just complaining about healthcare, and you're engaging them in healthcare, and what you find in those downstream revenues that come to the hospital pay for the operating expenses of the bus. So with that, we went to the drawing board, came up with a different design, and came out with this, which was a reproducible model that anybody could buy. I have no financial stake in it, but something that is an opportunity for where it fits. Anybody could copy what we were doing. Chattanooga sits in the eastern part of Tennessee. As you can see, we're geographically challenged with rivers and mountains and all the things that keep people from coming and getting their health care. So one of the things that we do in learning in the process is that you want to educate the community first. The day of the screening, we bring them into this front part of the bus where we just confirm who they are. They've already been registered. We also sign them up for HIPAA-compliant texting. They'll go next door, get their scan, and then after the scan's done, it's sent back through currently cell towers, soon to be Starlink, to the hospital. The radiologist read it in the next 30 minutes, and then you can generate an answer and report to the patient the same day. Our goal was that we needed to get not one person every 15 minutes, and we need to get somebody every 7.5 minutes. We wanted to get 50 people in an event. So if we drove there an hour, parked the bus, started screening for 6 hours and drove the bus back, we could screen 50 people, but we had to hit that 7-minute mark. We've done that, and now we think we can actually get it down to 4.5 minutes. So you're talking about the time you can fill up your car with gas, you can get health care, get answers same day, not only learn about yourself as far as your lungs, but with the AI piece, and we'll call this lung screening 2.0, you can start looking at a population health model. So what did that mean? Well, telehealth started in COVID, so we cut the number of people we had to have on the bus, nurse practitioner in particular. And if anybody walked up, which would always create some interest, what is this, what are y'all doing? And if somebody qualified or wanted to get scanned, we would have them through telehealth just talk to somebody back in our office. So we're using the personnel back there to sign them up in Epic, get all the paperwork done that didn't disrupt the flow. We started bringing in the AI into the workflow. Now the tech doesn't have to process any of the images. They can simply take the calcium scores and get it automated, so everybody with a low-dose CT scan is getting a calcium score with it. And then you start looking at what else is on there. Well, bone density. You look at aortic screening. How many people do you hear that say, well, nobody ever told me I had emphysema? Well, now you can give them quantitative measurements. What's their risk for flu season? And you can start extending into so many different areas. We had MIT came out with Sybil, which was a predictive program that takes the same CT scan data. You're looking behind the picture to the actual data and can look at an area in the lung in a high-risk patient, say in this spot over the next 6 years you have an 85% chance of developing lung cancer. You can mark that area on the lung. You can look at other components, but give you an idea of what's possible out of this 4.5 minute to 7-minute visit. You know, you take the heart out. You can show them, here's your coronary arteries, here's your disease. Your calcium score is this, here's what you should get on. And you start looking at our Tennessee population, I go back to almost half the people going to die of heart disease or lung cancer. You can put them on a generic poly pill, and you can reduce their cardiac mortality by 30%. You can look at aortic measurements. You can quantitate the lungs, the emphysema, what's their risk of pneumonia infection. Volumetric measurements, putting a lot of data into nodules that help us manage them more appropriately, not just biopsy everything, but also looking at things like your bone density. You look at core muscle. One of the biggest things that's fascinated me, because it really ties back into lung cancer survival, is the massive or increased abdominal visceral adipose tissue associated with a chronic inflammatory state, less survival stage by stage from lung cancer, but also is associated with diabetes, fatty liver disease, our number 7 cause of death. All this is visible on that scan that now with all these tools, you can act on it. So you're really going in with a role of lung screening, but you're coming out with a population health model of what can we do. So I mentioned initially one of our metrics was we had a 3-year goal of it either was going to work or not work. We had a city we identified that had a single primary care physician. She was a family practitioner. And it was in Spring City, Tennessee, about an hour and 15 minutes from Chattanooga, so within the range where we thought the bus should be going. Small population, 2,400 people, couldn't remember a lung cancer survivor, had a high prevalence of the disease. It sits in a county called Ray County that's 30,000 people, and we calculate there's about 1,200 people eligible for lung screening in that population. So we went, got buy-in from the local primary care doc and said we're going to go along this journey with her, and we had a 5-year goal of trying to change the population, and certainly anybody in a small community loves to help the attention and people coming to it. So this is Spring City, Tennessee. It truly is a one-stoplight town. During that 5-year time period, we screened over 500 people, 72 different programs. We found a prevalence rate of 2%, which is what you'd expect in a little bit higher risk population than normal. But the majority were stage 1s or 2. And our biggest surprise was the annual compliance rate with following up with imaging, almost approached what the NLST trial had shown. And part of that was engagement in the local primary care provider who helped us. Part of it was engaging the community of why they should be doing it, but also using HIPAA-compliant text messaging to stay in touch with them, to stay engaged with them, and particularly make sure they got back in for their annual scan. I tell this because on this journey, there were a lot of phone calls between this primary care physician and myself. In the early days, given they really were our first site we went to, it was a lot of things we screwed up, could have done better, missed, and it was a steep learning curve. She called me end of last year, which was at that 5-year point, and said, "You don't know what you've done." I said, "I got thick skin. Just give it to me. We're not quitting." She goes, "No, you've changed this town." I said, "What do you mean?" She said, "We have a dozen people walking around with lung cancer. In a small town of 2,400 people, you lose one person for anything, any cancer particularly. The whole town knows. They know what Coach Smith died of." And so they've been living this belief, the stigma that lung cancer takes everybody's life. She also said, "You now don't sign anybody up. We sign all the people up. In fact, these lung cancer survivors are in the community signing people up for your events every time you come. So we'll go up there and we'll scan 50 people in this small county because they signed themselves up." So it just gave me hope that, just like in Mississippi, if we make healthcare simple, we make it easy, I truly believe we can change not only our cancer survival rate from lung cancer, but by disrupting the healthcare delivery system, giving them what everybody wants, something simple and easy. We certainly reach the most vulnerable. It creates a lot of attention, which is part of the educational struggles we had early on. You definitely can reduce lung cancer mortality by 20, some studies in European models as high as 39, 40%. Simply taking those with a high calcium score on no management, have no knowledge of their disease, you can reduce their mortality by a third. Now think sitting with Governor Lee saying, "I have a simple tool that's inexpensive, costs less than a sidewalk on a street in Memphis or Chattanooga, that will reduce your mortality of what half the people in Tennessee die of by 30%. What does that do economically to us? What does it do to our most precious asset, which is human capital?" He goes, "If you can pull that off, you'll change our state." I said, "Well, it turns out it's a lot easier than we thought. It just takes a different approach." I also think we'll improve quality of life, simply addressing osteoporosis, weak core muscles, the degree of emphysema, things that do impact diabetes, unrecognized diabetes, things that you can change. And the great thing of all this is that it started just literally as a simple idea that came from a trip to Mississippi that's turned into something that I think is reproducible, and that's why we're going to start working on bringing it to southern Louisiana. It's not for every state. Probably Chicago or a New York City is going to be harder to pull it off. Nashville, it turns out, has lots of access to imaging centers in the middle part of our state. Less beneficial, but I think there's a whole bigger piece to this. Currently, the VA system's adopted it. Cancer Moonshot's now a part of it. I've been called to the office, the school principal's office. I've never been called to the White House for anything, but certainly what you get is that I think what everybody's craving for is a ready-made solution to make healthcare simple and easy. If I go back to what was one of our original problems or frustrations I had was messaging and education. So I came home one night, and again, my advisory panel of my wife and hound dogs said, "You need some socks." I go, "Well, I have socks." I said, "No, you need these socks." She goes, "You've got to have a reason to tell people about what you want to talk about. You can't go up to people and just say, 'Hey, I want to tell you about lung screening.' It's just not okay." But if they ask permission by saying, "What is that sock?" now you get your 3-minute elevator speech. So we've tested it out. We've had young people, high school students, we go into schools and try to change the stigma, have them wear the socks, produce reels, Snapchat or Instagram pictures, post them with the hashtags. It directs everybody to a landing page that whoever's looking at it will learn a little bit more about lung cancer and the benefits of lung screening. And we're going to try to pull off, which is lofty, a national Socket to Lung Cancer Day. We get everybody to kind of post pictures, direct them to an information. How do you get screening? What's the closest screening site? We've got to be creative in ways of how we disseminate the information. That was really part of our biggest struggle when we started out this whole journey, was people just didn't know about it. And today's social media platforms and our tools we have, we can do a whole lot better. It's just taking a thoracic surgeon to get out of the operating room and to listen to some people in rural Mississippi his wife, and his hound dog. And it turns out it's not that difficult, but it's reproducible and scalable. So stay tuned. Louisiana, I think this fits for y'all state just like it does Tennessee and Georgia and Mississippi and Kentucky and West Virginia and all the other states that we're pulling this off on. And it's a good way to end the conference with a positive note and something to look forward to in Louisiana. So thank you all. Yeah.
We're going to be talking more about
Okay. All right.
I want to, how about a tremendous thing with Dr. Headrick? We want to, you have a question? You have $5? Oh, no, go ahead, Doc. Come on up.
Real quick, this is spectacular. I'm just curious to know, do you incorporate, say, a drop of blood at the same time, or some kind of other, lab testing along with the imaging?
So we're currently working with a grant from the federal government on what lung screening 2.0 really could be. The challenges, and a lot of that is the cost of some of those tests, but also slowing down the screening process. And I really felt like if I can go to these communities, scan 50 people, get back home, get everybody put up and not work overtime, then that was really my main goal. And then use AI and modern technology to help execute it. United Technologies now has a scanner they want to put on the bus that's completely automated. There's not even a radiology tech. You look at how quickly things can be processed and how much information is on there. What we want to do is be responsible, so also make sure we're not scaring people, but what is the most meaningful thing that can change a population? Give them 1 or 2 or 3 simple things to focus on. In Georgia, they're looking at incorporating PFTs, looking at vaccinations for flu season. There's a lot of other things they're going to try to bring on board. I think we're all figuring this out, so it's wide open, but I go back to our goal was initially to cut lung cancer mortality and try to sneak our way into population health in a meaningful, inexpensive way of taking care of people. $3 trillion, $4 trillion reaches all the way to $1 trillion stacked $100 bills goes up to the space station and back 4 times. So $4 trillion is just unthinkable, and yet we're not gaining anything from it. I think this will save money and save lives.
That's awesome. Awesome. Thank you again, Dr. Hendricks. We'll be talking more with you, no doubt. And this concludes our conference. I'm Rich Marty I'm the Vice President of CAGLA. Chad is my boss. He's everybody's boss. But we want to thank you so much for your participation this year. As you can see, we're growing pretty rapidly. It's our 3rd annual, and content like this is what we're all about, right? I think between our Google guy, Scott, and AI, and Troy in the back, tremendous good friend, and the talent that we've brought to you guys. But we need your feedback. We need to know what you need to know, and one of the other things we want to grow it. I mean, the way we can do some of these things and have an impact is we have to have more people involved. We have to get politically involved. We have to have all these things to come together so we can move the needle and reach people. So we're asking you to spread the word. And we're open to contact, spread the word. You have people that are interested. We need to know about it. You need to tell them what we're doing here with the conference so we can gather this momentum and keep this wave going, because we're going to make an impact. There's no doubt about it. I'm convinced after this convention more than anything. And we've been raising money for 45 years with the Marty Cancer Fund, and we're going to fund stuff like this. And maybe we don't even have to fund it. We're fundraisers. Maybe the state is going to do it, and we're going to talk more about that. But it needs a collaborative effort from everyone to do this and to make an impact. And Doctor, you've done a phenomenal job. I'm so impressed with what you're doing, and I think it's the tip of the iceberg, as you said. So again, thank you all for being here. Just spread the word for us. Everyone be safe, and make sure that you make it to the crawfish boil that's coming up. The bus will be out here at quarter to 5. There'll be a bus taking you to St. Charles. For those of you that don't eat crawfish, we have very, very good fried chicken. You'll probably need one of the screenings after that. But Copeland's fried chicken. So please enjoy that. We hope you had a great time. We hope you spread the word, and be safe getting back to wherever you're coming from. Thank you very, very much.